So the European guidelines were just updated in August of 2025 and presented at the European Society of Cardiology Congress. And so it's a really interesting time to look at how valve disease guidelines have shifted. So if we just think about the US guidelines, they were last published in 2020. And so we're currently in an update process for the American guidelines. But the European guidelines do take into account the most recent literature, and so it is worthwhile, I think, to review what those are telling us while we wait for what the ACC-AHA guidelines are going to be. One of the key updates has been that TAVI now has a 1A indication in Europe for patients over the age of 70 as primary therapy for aortic stenosis. And probably a lot of people are already doing this, but I do think it's important to recognize that this is now a 1A indication. So any patient over the age of 70 that has severe aortic stenosis has an indication for transcatheter aortic valve replacement. One of the key messages of the European Heart Guidelines is that we need to make these decisions in a multidisciplinary team and the focus on shared decision making. So the real focus on making the patient part of this discussion and taking patient wishes and decisions into consideration. A lot of the investigations that we do prior to transcatheter or even surgical aortic valve replacement has consisted of coronary angiography. And now for patients that we're considering for a transcatheter aortic valve or TAVI, we don't necessarily need to do that. And so if you have your coronary CT and it shows that there's not significant coronary artery disease, we no longer are required to move forward with a coronary angiogram in all these patients. And I think about when we think what these patients are going through and all the tests that they're having, if there's one we can eliminate, if we can safely remove a coronary angiogram, the guidelines are now in support of that. So I think that's an important change in terms of the workup and all the tests that patients need to have. The second thing I think that's really important about these guidelines is how we look at secondary mitral regurgitation. We have now recognized in the European guidelines that there are two types of secondary mitral regurgitation. There is what we call atrial secondary mitral regurgitation and ventricular secondary mitral regurgitation. And so to put that in context, atrial secondary MR is what we often see in patients with atrial fibrillation. So we get dilation of the left atrium, dilation of the mitral annulus, and that's very different from patients who have heart failure and reduced ejection fraction. And so the ESC has now officially recognized this as a separate entity, atrial functional or atrial secondary MR. And for this, surgery is considered a 2A indication to replace or repair the mitral valve, and transcatheter repair is considered a 2B indication for this particular type of mitral regurgitation. The other one that is very near and dear to me is secondary ventricular MR. So now we've separated these out. I mentioned atrial. Ventricular is what we would commonly see. So patients who've had a previous MI in the past or who have lower ejection fractions due to a cardiomyopathy. And this is where the COAPT trial studied mitral TEER with the MitraClip. We now have 3 trials for that. We have COAPT, we have MITRA-FR, and we have ReShape. And this has led to a 1A indication for mitral TEER or MitraClip for patients who have secondary ventricular MR. And I think this is a huge update for us. Those of us who have been doing this procedure for a long time, I've been doing it for 15 years, we now have an indication to be able to treat these patients and offer them a therapy as a 1A indication in the guidelines.